Hi, my name is Gabrielle Schafer, and the topic of my project is thyroid cancer. The thyroid is a butterfly-shaped gland located at the front of your neck, just below the Adam's apple, and consists of the left and right lobes. The thyroid is an endocrine gland which defines the way the hormones are secreted. Endocrine secretion is characterized by directly secreting into the bloodstream, whereas exocrine secretion, such as sweat glands in the skin, secrete substances into a ductal system to an epithelial surface. The hormones the thyroid is responsible for secreting include T3 and T4. These hormones play an important role in metabolism, brain function, and many other bodily functions. Thyroid cancer is the most common type of cancer among the endocrine system and occurs when malignant nodules grow in the thyroid gland, though over 90% of nodules are not cancerous. In recent years, thyroid cancer has become more prevalent, averaging about 62,000 new cases a year. It is considered to be the fastest increasing cancer in the United States for both men and women, and is the fifth most common cancer for women in the US. There are three types of thyroid cancer: differentiated, medullary, and anaplastic. Differentiated thyroid cancer accounts for over 95% of all cases and originates from thyroid follicular epithelial cells. Under this category of well-differentiated thyroid cancers are papillary thyroid cancer, follicular thyroid cancer, Hürthle cell thyroid cancer. Papillary thyroid cancer is the most common subtype and carries the best prognosis. If metastasis occurs, it is more commonly to cervical lymph nodes and less likely to spread further. Follicular thyroid cancer, Hürthle thyroid cancer, and poorly differentiated types of thyroid cancer are higher risk and more likely to metastasize through the blood to distant sites, particularly the lung and bones. In contrast to well-differentiated thyroid cancers, medullary thyroid cancer originates in the parafollicular neuroendocrine cells of the thyroid and commonly presents as a solitary thyroid nodule in patients. Medullary thyroid cancer accounts for 1 to 2% of all thyroid cancers and is more likely to run in families. Lastly, anaplastic thyroid cancer is an extremely rare form of thyroid cancer, less than 1% of all cases, that typically presents as a rapidly growing neck mass. Upon examination, most patients with anaplastic thyroid cancer present a large, firm, palpable mass in the thyroid. A biopsy will immediately follow, and distant metastasis to the lungs, followed by bones and brain, is commonly revealed. Another interesting factor of anaplastic thyroid cancer is that it can either occur with another type of thyroid cancer or it can occur alone. Patients with this type of thyroid cancer are often referred to a center with expertise in treating it. To diagnose thyroid cancer, a biopsy of a node is required. Prior to performing a biopsy, blood work can be done to test the thyroid secretory state, which can be used to measure the level of thyroid hormones, although it is only sufficient in determining if the thyroid is functioning properly. Once a patient has been diagnosed with thyroid cancer, further diagnosis is done using a T and M lettering system. With this system, T for tumor will use numbers 1 to 4 and describe the size and location of the tumor. N for node is used to stand for lymph node and only uses number 1, but also uses N1A and N1B to explain how the cancer is spread in the lymph nodes. Lastly, M for metastasis only uses the number 1 and explains if the cancer has metastasized. This is an example of a larger non-invasive tumor, T2, with no spread to lymph nodes and no metastasis. Symptoms of thyroid cancer could include a lump or swelling in the neck, persistent pain in the front of the neck, sometimes going up to the ears, voice change, dysphagia, constant cough, and difficulty breathing. Thyroid cancer is one of the few cancers that has increased in incidence rates over the recent years. Certain factors increase your probability of getting thyroid cancer in your lifetime, but like many other cancers, the earlier it is detected, the greater the prognosis. Common factors include family history, gender, age, prior radiation exposure, iodine deficiency, previous diagnosis of breast cancer, particularly in the first 5 years of diagnosis, and an abnormal RET oncogene. Looking at the statistics for thyroid cancer, the number of new cases for women in their 20s is 5 times that of men. Thyroid cancer is the most common cancer in aged 20 to 29 and second most common for women that age. And overall, women are 3 times more likely to get thyroid cancer, but still have similar mortality rates, which means men typically have worse prognosis. Looking at this graph, you can see the incidence rate per 100,000 people comparing females and males during the years of 1993 to 2017. It is evident that a greater number of women get thyroid cancer in comparison to that of men. Overall, the 5-year survival rate when looking at all factor stages and other types of the disease is 98%, which is why thyroid cancer is often known as the good cancer. But the margin between different types of thyroid cancer grows when comparing localized, regional, and metastatic. Localized thyroid cancer means it is only located in the thyroid and comprises about 2/3 of all cases. The 5-year survival rate is about 100% for papillary, follicular, and medullary, but only 31% for anaplastic. If the thyroid cancer has spread to nearby tissue, organs, and/or the regional lymph nodes, it is considered to be regional. The 5-year survival rate for regional papillary is 99%, follicular is 96%, medullary is 90%, and anaplastic is 12%. Lastly, cancers that have distantly spread to other parts of the body are considered to be metastatic. The 5-year survival rate for metastatic papillary is 78%, follicular is 63%, medullary is 39%, and anaplastic is 4%. Medullary and anaplastic diagnosis only make up 5% of all thyroid cancers, but are most likely to spread. Most thyroid cancers have mutations along the mitogen-activated protein kinase cellular signaling pathway. This pathway is responsible for transmitting growth signals from the plasma membrane to the nucleus and plays a main role in the regulation of cellular proliferation. This photo shows a signaling pathways involved in thyroid cancer. The box on the left shows the mitogen-activated protein kinase pathway, which begins with activation by mutation in most thyroid cancers. This event then initiates thyroid cancer development and leads to altered gene expression, which promotes cell proliferation, cell growth, angiogenesis, and loss of differentiation. In the box on the right, the pathways altered in advanced thyroid cancers are shown, which are believed to promote tumor progression. The mutation most seen in non-medullary thyroid cancer is the BRAF T1799A mutation, resulting in BRAF V600E mutant kinase, which is exclusive to papillary thyroid cancer and papillary thyroid cancer-derived anaplastic thyroid cancer. Mutations in the RAS family of oncogenes occur frequently in follicular thyroid cancer and follicular variant papillary thyroid cancer. Chromosomal translocations also occur in thyroid cancers, and these genomic rearrangements lead to the expression of novel fusion oncogenes that initiate events in many thyroid cancers. Some pathways of translocation occur more frequently than others. The less common translocation partner genes are seen infrequently but can directly affect treatment. For example, ALK rearrangement might be associated with clinically aggressive thyroid cancers, and the availability of small molecule ALK and NTRK gene family inhibitors have shown clinical promise in rearrangement positive tumors and other cancers, which proves that the identification of these rearrangements could prove to have therapeutic relevance to patients with thyroid cancer. There is still a lot of debate regarding the clinical implications of individual mutations, with findings from some studies suggesting increased propensity for clinically aggressive papillary thyroid cancers in tumors bearing a BRAF mutation. Although recognizing that about 50 to 70% of papillary thyroid cancers harbor a BRAF mutation suggests there are other important determinants of clinical behaviors. Plus, mutations in TERT have been identified in more aggressive subsets of papillary thyroid cancer. Findings from DNA sequencing studies of poorly differentiated thyroid cancer and anaplastic thyroid cancer suggest that there are other mutations contributing to tumor progression. Commonly, p53 tumor suppressor pathway is present often in association with an early initiating mutation such as BRAF T1799A. Treating cancer, a transdisciplinary team is usually required. For thyroid cancer, this may include a surgeon, medical oncologist, radiation oncologist, radiologist, nuclear medicine physician, and endocrinologist. The treatment will be determined by the type and stage of the cancer, possible side effects, patient's health, and the patient's preference. The first option is surgery. If the patient undergoes surgery, they could receive a lobectomy, subtotal thyroidectomy, or total thyroidectomy. All of the surgical options involve removing part of or the entire thyroid, but surgical options aren't recommended to all patients, especially because removal of the thyroid at any degree will require hormone replacement medicine for the rest of the patient's life. Another possible course of treatment could be a lymphodectomy, which is the removal of the lymph nodes in the neck. Any of the surgical procedures could result in damage to the nearby parathyroid glands or damage to the larynx. In addition, some tumors may be inoperable and other treatment options will be recommended. Another possible treatment option is radioactive iodine. This is an option for patients with papillary follicular and Hürthle cell thyroid cancer. Radioactive iodine is used to treat differentiated thyroid cancers that have spread to lymph nodes or distant sites. This treatment is not feasible for patients with medullary thyroid cancer or anaplastic thyroid cancer. This treatment requires a low iodine diet for 2 to 3 weeks beforehand to allow the treatment to work most effectively. Some long-term side effects of this treatment are possible infertility and second-term cancer risk. External beam radiation therapy is another type of radiation therapy in which high-energy X-rays are given from a machine outside the body to destroy cancer cells. This typically consists of a specific number of treatments over a set period of time. Specifically for thyroid cancer, this may look like 5 days a week for about 5 to 6 weeks. This treatment is only used when later stage thyroid cancer has spread to critical areas. Treatment is concentrated to a certain area, only affecting the cancer cells, and follows after having surgery. The next option is therapies using medication. This encompasses chemotherapy and targeted therapy and can be done either through IV or orally. Chemotherapy is the use of drugs to destroy cancer cells by preventing them from growing and dividing. Side effects include fatigue, risk of infection, nausea and vomiting, hair loss, loss of appetite, and diarrhea. Targeted therapy is a treatment that targets the cancer-specific genes, proteins, or the tissue environment that contributes to cancer growth and survival, while limiting damage done to normal cells. The FDA has approved target therapies for different types of thyroid cancers. For papillary and follicular thyroid cancers, there are 2 approved target therapies. For medullary thyroid cancer, there are 2 FDA-approved target therapies. And for anaplastic thyroid cancer, there is 1 approved targeted therapy. There are many factors that go into determining a treatment plan, which is why an interdisciplinary team is vital. The paper I choose is development of a functional thyroid model based on an organoid culture system. Thyroid follicular cells in mammals have a low turnover rate, averaging about 5 renewals per lifetime in human. This factor of thyroid cells has presented long-term culture and propagation to be challenging. Comparatively, other organs such as the small intestine and colon have already had long-term culture systems developed in which single stem cells derived from an organ and digest from stereotyped organoid structures. In this culture system, the stem cells are able to replicate and generate differentiated cells when niche factors are ideal. Other organs, including the stomach, esophagus, pancreas, liver, and prostate, that have established organoid culture systems, but this is not the case for the thyroid. One major factor is that the thyroid stem cells are not well known, but the establishment of this culture could be useful for the characterization or gene transfer experiments. Tumors induced by thyroid follicular cells include papillary thyroid cancer, follicular thyroid cancer, poorly differentiated cancer, and anaplastic thyroid cancer. This image shows the function of the thyroid organoids in vivo. Section A represents a transplantation of thyroid organoids under the right renal capsule of mice with hypothyroidism due to iodine-induced thyroid ablation. Section B shows the uptake of iodine by the right kidney containing the transplanted thyroid organoids by the normal left kidney. Section C shows the phase contrast image and analysis of GFP and thyroglobulin for sections of the right kidney of mice transplanted with thyroid organoids. In section D shows H&E staining and autoradiographic image obtaining with bioimaging system for sections of the right kidney with mice transplanted for thyroid organoids and injected with iodine. And the arrowheads indicate localization of radioactive iodine. Their findings suggest that this newly developed thyroid organoid culture system is a potential research tool for the study of thyroid physiology and pathology, including thyroid cancer. Here are my references, and thanks for watching.